morning, good afternoon, and good evening, and welcome to the IFa's Global Café. My name is Katrina Mazanis. I'm the Director of Policy Advocacy and Innovation here at the IFA, and today we will be delving into the concept of reablement, which is a transformative approach that focuses on empowering individuals to regain their independence and improve their quality of life. Reablement is not just about providing care, but it's also about enabling individuals to do things for themselves, fostering a sense of autonomy and competence. And so we also take a closer look at reablement in dementia care specifically. And so joining us today for our conversation is Dr. Silke Metzelthin. Dr. Metzelthin works as an associate professor at Maastricht University at the Department of Health Services Research within the Care and Public Health Research Institute. She's the vice chair of this research institute, along with the research line Aging and Long-Term Care. The research group conducts unique research on the interface of different disciplines such as nursing science, gerontology, health sciences, medicine, data science, technology, and service science. In addition, she works as a scientific advisor at the Living Lab in Aging and Long-Term Care, which is a sustainable and successful formal collaboration between research, teaching, and care organizations providing long-term care. And so her research specifically focuses on innovative interdisciplinary interventions for frail older people, taking into account innovative care concepts like reablement or function-focused care. So welcome, Silke. Really nice to have you with us.
Welcome, and thank you for inviting me to this session.
Yes, so we always kind of like to start by learning a little bit more about yourself and your background. So can you just tell us a little bit more about yourself and how did you kind of come to where you are today?
Yeah, I think you already did a great job in summarizing my background. Maybe in addition to that, from background, I'm an occupational therapist. And after my bachelor in occupational therapy, I did a master in health sciences research. And back in that time, also my interest for research was developed, especially in the field of care for older people. So afterwards, I also decided to do a PhD. So I did a randomized control trial and I investigated the effectiveness of preventive home visits for frail older people. But unfortunately, the intervention was not beneficial compared with usual care. So after my PhD, I had to do some reorientation. But I was still interested into the question, what can we do for older people to enable them to have a meaningful life and preferably also to stay in their homes for as long as possible. So then I had to look at the literature and I came across the concept of reablement or restorative care, function-focused care. These are similar terms for the approach. And I reached out to several well-known researchers in the field of reablement. So from the United States, Professor Barbara Resnick, and in New Zealand, Professor Matthew Parsons, in Australia, Professor Jill Lewin. And I tried to learn from their experiences. And within our Living Lab in Aging and Long-Term Care, we also translated the knowledge to the Dutch home care setting because, of course, every healthcare system is different to some extent, but I think the problems that we experience in the daily work are the same. I think therefore it's very good to also collaborate internationally.
Absolutely. And I think we'll hopefully have the chance to touch on kind of some of those learnings later on in our conversation. So I think first, just to sort of set the scene, can you explain what reablement is and how does it contribute to healthy aging or preserving or regaining function in older people?
Yeah, to be honest, there was, at least some years ago, there was still a lot of discussion about what is reablement and maybe also still nowadays for a little bit. But we also worked on an international definition of reablement on behalf of the Able Network. And according to this definition, reablement is a person-centered approach in which interdisciplinary team works on the goals of clients. So it starts with a good conversation and a comprehensive assessment. Consequently, aims are set together with the client. There's a support plan developed, and based on that, people are supported by the team to reach their goals by applying different interventions. For example, thinking about helping aids or involving the social network, but also train people, for example, in physical activity or in daily activities. Yeah, to enable them to do their meaningful activities.
Mhm. And then you mentioned the kind of Reable network. And so I'm wondering, and I know you kind of already briefly mentioned that group and the work that you're doing through that group, but I'm wondering if you can just tell us a little bit more about what the goal of the network is, and to what extent have you contributed to kind of the implementation of reablement in the Netherlands and also around the world.
Yeah. Yeah, the Reable network was established a few years ago in 2018 by a professor from Denmark, Tine Rosgaard. So we started with a relatively small group, so approximately 20 researchers from Australia, New Zealand, the Scandinavian countries, the US, Canada, and the Netherlands. And yeah, nowadays, so during the last years, the network also has grown. So nowadays we have more than 80 reablement experts from 11 different countries. And we have, for example, also written a book about reablement. So what do we know already based on previous research? What do we know about the effectiveness, the experiences of participants, but also how has reablement developed over the years in the different countries, and what helps when implementing reablement, and also some futures perspectives.
Mhm.
And yeah, one of the actions that we've done in the beginning was indeed the Delphi study to come to the reablement definition. And also nowadays we have regular webinars to also update each other about the most recent research experiences and results.
Mhm. Yeah, thank you. I'm wondering, maybe as a follow-up, if you can share, maybe just a really brief snapshot of some of the practices that you've highlighted through this group. What is the kind of status of implementation in terms of reablement in some of the work that you've done, and to what extent is this being implemented in different types of settings?
Yeah, yeah, we see based on the inventarization that we have made that reablement is implemented in all different settings. It's a lot implemented in home care, but you can also see it in, for example, nursing homes, in a hospital setting, assisted living. So it can be broadly implemented.
Mhm.
If you compare the different countries, then we see that there are some differences how well it is implemented already. So some countries are really in the beginning stage and doing first pilot studies, for example, with reablement, while in other countries, reablement is also part of the usual care system. So, for example, in Denmark or New Zealand.
Mhm. And then that kind of brings us as well to talking about how reablement is being applied to dementia care. So can you share with us a little bit about that? What does reablement look like specifically in the context of dementia care?
Yeah. Yeah, I think the pity is because the international definition also says that reablement is for everybody, irrespective of the age or a diagnosis or the setting. But we see often in practice that people with dementia are often excluded from studies because people also think that reablement is strongly associated with recovery and independence. And of course, that is only possible to a limited extent if you work with people with dementia. But we think that you also can reach some valuable outcomes in this group because you can contribute to the well-being of people, and with the right support, they can also maintain their autonomy and also partly their independence.
Mhm. So, what types of, how do kind of sort of maybe the final outcomes differ, the goals that you're aiming for differ when you're dealing with, maybe a more general population versus those with dementia?
Yeah, yeah. For example, also if I have a look at the Netherlands, there we often apply reablement nowadays also for people with somatic problems, and yeah, of course, there you aim at recovery and also to and enable people to be independent again after a period of 8 to 12 weeks. But I think if you work with people with dementia, you also should also aim more for well-being, for example, and autonomy and outcomes like that.
Mhm. So, what are some of the benefits that I guess reablement has for those with dementia, and how is reablement maybe addressing some of the care challenges in the setting?
Yeah, there are a few big studies conducted that specifically focus on reablement in people living with dementia. So, for example, in the UK, you have the GREAT trial, and in Australia recently also the IHOP trial was finished. And what we see in these studies, but also in other studies, is that you have beneficial effects on different levels. So first of all, people themselves experience a better quality of care, but also, for example, informal caregivers also can handle their caregiving burden more efficiently. They experience a better quality of life, less caregiver burden. And in a few studies, we have also seen that reablement in dementia care can contribute to cost savings or cost effectiveness
Mhm.
of the care.
So maybe I'll jump to sort of following up on that caregiver piece. So, how does reablement really support caregivers in maybe a dementia care population, but also just generally? And, are caregivers being engaged in this type of work?
Yeah, yeah, I think the informal caregiver or the family caregiver is a very important person in reablement for the more generic population, but especially for people with dementia, because yeah, they can also be educated in ways how they can support their loved ones in reaching the client's goals. Um, but of course, we also should pay attention to their well-being and their quality of life. So we also try to reduce their caregiving burden and also to work on their personal goals. And I think what also comes on top is that, of course, as a family caregiver, you also care about your loved ones. So sometimes also safety is an issue, and that is also a threat for the autonomy of people themselves.
Can you
Because
elaborate on what you mean by safety? Like in what aspect, or maybe some examples?
yeah, that family caregivers are afraid that, for example, their loved ones will have an injury or will walk away, stuff like this.
Mhm.
So you have to make sure that there is a balance between, on the one side, the safety of persons, and on the other side, also the autonomy,
Mhm. Mhm.
so that that it does not lead to involuntary treatment, for example.
Mhm.
You
Yeah.
take decisions for your loved ones, or that you yeah.
Mhm. So I think that that's maybe a good segue into kind of the importance of centering the person when coming up with these sort of care strategies. So what are some maybe best practices in terms of having kind of the reablement services provided be really person-centered? And so you've mentioned the caregiver, you've mentioned a little bit about, the autonomy of the, patient or the client or the person at the center. But are there any sort of best practices, how have people sort of maintained person-centeredness when delivering this type of care?
Yeah, I think first of all, it's very important that you have the good conversation in the beginning about what is the person like? What are the interests? What are the habits of the person? What were roles in the past that you really get to know the person living with dementia? And based on that, you can have a conversation about meaningful goals. And if this is not possible anymore, for example, in a moderate to late phase of dementia, you can have, of course, also the conversation with the family caregiver.
Mhm.
And what is also very important that you do not only have a look at the cognition issues, but that you also analyze the situation and the impact, for example, of the environment.
Mhm,
You
mhm,
really have a look. What are the consequences of the cognitive issues on the daily functioning of people in their own environment?
mhm, mhm. So I'm gonna just jump to some of the questions that have come through in the chat here, and I think this will maybe kind of help contextualize a little bit, the how reablement care is actually kind of implemented. So we have a question from Shmuel that's asking, what, according to your opinion, needs to be the role of governments and authorities in the adoption of reablement care?
Yeah, I think the government has an important role in integrating reablement also in the usual care system in the countries, also to increase accessibility of reablement services. And what we also see again and again in our studies, that also the funding system has to be supportive for reablement. So, for example, in the Netherlands, it was a long time that we had in home care fee for hours funding. And of course, then it's not attractive for a healthcare provider to deliver less care.
Mhm,
So now we are looking for different funding systems. So, for example, lump sum funding or case mix funding, where you get a specific amount of money, and then as a healthcare provider, you can decide on your own how you spend the money.
mhm, mhm. Is that something that has been implemented? Have you, or has it only been kind of
Yeah,
presented?
I think in New Zealand, that is a country which has the most experiences also with a supportive funding model for reablement.
Mhm, mhm,
Yeah, because they work with case mix, and then based on the client characteristics, they allocate the money to the persons.
mhm, mhm. And I think that sort of leads me to a question about sort of the healthcare providers, or the care providers that are delivering this type of care. What sort of training goes into it? You mentioned that it's, quite a lot of time, which doesn't really lend itself to these fee-for-service models that, exists in a lot of the world in terms of how we deliver care. And I think something that we hear quite a lot, in honestly various facets of our work, is that healthcare providers just don't necessarily have the time to really, have a really in-depth conversation with the patient, or really kind of work through a lot of these goals. So how do you sort of rectify those two things, and what sort of training goes into um, ensuring that healthcare providers can provide this type of care?
I think there are two things. On the one hand, the staff has to think differently about dementia. and also about how good care looks like. So because a lot of healthcare staff is used to take over tasks from people if they get older or if they get sick, if they develop dementia. Um, because we believe people cannot do it on themselves. But instead of that, we should have a look at their capabilities and ways how we can support them to be as independent as possible. And that is really a mind shift that people have to undergo, and that does not happen from one day to the other. So I think therefore it's very important to offer also training and coaching to staff members.
Mhm.
But I think it's also very important to also have a supportive management, for example, that you have good leaders who also give you the time and the resources to work according to reablement.
Mhm. Mhm.
And yeah, that they create an environment where you also try to allowed to try out new things. And if yeah, you also have to be a strong team together with your colleagues.
Mhm.
Right.
Yeah, absolutely. So I'll just go back to the chat here just to maybe pose a few additional questions. Um, so there is a question on how do sort of cultural perspectives on aging and dementia influence the acceptance of reablement?
Mm, yeah, I can imagine. I did not do research about that specifically, but I can indeed imagine that in some countries, yeah, you would like to care more for your relative than in others. And that I can imagine, for example, in the Southern European countries, that you may be, yeah, because there the family is also very supportive, that it's maybe more difficult to implement reablement over there than in other countries where people are more independent, for example.
Mhm. Mhm. Um, and then maybe there's a question here from Shirley. Shirley, did you want to unmute and pose your question? If not, I can also pose it. Oh, yes.
Yes. Uh, Thank you.
Mhm.
Um, in my experience in working with those with dementia, the importance of establishing a normalcy to what they previously had as closely as possible, but also a routine, and then slowly conditioning them for individuals with dementia. I'm wondering if you can comment on that.
Absolutely, absolutely. I think that's really important to really to know the person with dementia. What are their habits? What are they used to do, and how are they used to execute some activities? So, for example, are they used to take the shower, or are they used to wash themselves at the washing table? And also, how do they do that? And that you also adapt your working routines to their routines, and then slowly try to learn them other things.
Thank
Yeah,
you.
definitely. So I think that's also a big difference between reablement for the more generic population and people with dementia, that you also have to adapt your learning strategies in this specific group, and that of course also asks some additional capacities from the reablement staff, that they have to have a good knowledge about dementia care and yeah, the effect that dementia has on learning capacities, for example, and what are effective learning strategies.
Mhm.
Thank you so much.
So, maybe another question in terms of the implementation. So, there's a question in the chat on, is there any key lessons and best practices learned from New Zealand, given their experience in this area?
Yeah, maybe for me it's easier to speak from the experiences in the Netherlands. So there we have indeed seen that it's very important to first work on the mindset, that people have the right mindset, and not only the staff members, but that you also take the clients themselves and the family also. That you also spend attention to them, and that they also have to understand the idea about reablement. Then it's also important to have enough resources to have supportive management. You need to definitely also need to invest in some capacity building, so offer training or coaching. And what we've also seen is that while people are working in reablement teams, that they also learn a lot from each other about ways how to reach the client goals, because they have this interdisciplinary expertise.
So I think, maybe what would be helpful is to kind of understand what other sort of advocacy efforts are needed. And maybe this is through sort of the Reable group that you're working with, or, how can this be further implemented, and but also how can kind of best practice be optimized, and what sort of advocacy efforts are needed, whether that's from, healthcare providers that are doing this work or researchers like yourself.
I think it's partly, of course, researchers can contribute to taking the next steps by doing more research about reablement, especially in dementia care, which is still in the early phase, I think. So we should do more research into the effectiveness of reablement in dementia care, especially with regard to long-term care outcomes, because we also believe in the preventive value of reablement, so that you can also postpone or prevent, for example, nursing home admissions, but therefore you have to follow up people for a longer period of time. It's also important to get to know more about facilitating and hindering factors for the implementation of reablement. But we also should do more research into how does reablement works, in whom and under which circumstances, because that could be different in each individual situation. But beside that, I think it's also very important that also the government takes a role in promoting reablement approaches. Because I think nowadays it's often also sell as a way of reducing costs. And I think that is not the best story to tell to people, because then people are afraid that you're taking care of them. And I think the government should emphasize much more the positive effects of reablement, that people, for example, are having more self-confidence, and that they experience more autonomy, and that they can still do the things they like to do. And I think that is a more positive story that also could help in implementing reablement in the society, because then people are more open for it and are not afraid that they lose their services.
I think from what I'm hearing, it sounds like there's sort of a best of both worlds, right? Like governments, might have kind of experience cost saving, but also we know that this sort of, if people can be more autonomous and have more function, that's also kind of good for our societies and our economies in the long run, but also that also benefits people in their quality of life. Does that kind of capture it?
Yeah, and maybe to add to that, I think also there's a big responsibility for health and social care providers, that they, for example, also integrate reablement in their strategy, and that they invest in the capacity building, and that they also educate not only the staff members but also the managers to create a good base for implementing reablement.
So we do have a question in the chat from Jane. Jane, did you want to unmute and pose your comment or question as well?
Yes, hold on. Let me put myself on video. Good morning.
Um,
Yeah, it's not really a question. It's just, the work that we've done in the last 8 years on a community-based person-centered care model. We are linked with the UK, the European Society for Person-Centered Healthcare. And it is actually a quite a complex area to follow up. You have to have the staff, the continuing training continuously with personal support workers, your healthcare staff, your internal staff as well. And what we found was doing a medical assessment when you first get a client. Yes, we're asking about the person a little bit, but we find that those assessments that home care agencies are doing or community agencies are doing are quite overwhelming and tiring for the client and also for the essential care partner. So what we're doing is breaking that down. We're doing more of the medical assessment, more of the medical lens. And then a couple of weeks later, when things are more settled, we go back into the home and we've developed a snapshot of me. And I basically put the information into the chat. So we've broken it down and not making it overwhelming, but we're still getting that information. And as you said, having that meaningful conversation, of information that you're gathering. So definitely creating the social networks. You need to know who's coming into the home. Who is that individual seeing? If they're in retirement or nursing home, who are the friends that are still coming to visit? Are they partaking in the social programs? Are they connecting with outside in the community as well? Knowing about community agencies. So this is something that is not being done, by private home care agencies. So we really, have taken home care to the next level and a benchmark, I think, for private home care organizations, so which is a little bit different than the community-based organizations as well. But we're getting a lot of feedback and, a lot of people are asking us to come and present so they can, pick up ideas that they might be able to use in their organizations. So thank you for your conversation today. Thank you.
Thank you so much, Shane. Yeah, did you have a response?
Yeah, I totally agree that it's maybe it looks more simplistic as I've told you. So indeed, in practice, it often takes much more time to really get to know the other person and also to get insight into the whole system around the person living with dementia. But I think that's also not a problem if it takes a couple of weeks, for example, as long as you have this conversation. And I think that is also a problem nowadays, that staff have this conversation one time in the beginning, and then they check the box, but they did not come back to that, and then they struggle in supporting the person in the right way or to set goals together with them because they do not know the person well enough to deliver right services.
Yeah, I think Jane, also your comment kind of really highlighted the number of different sort of people that are involved in this work. So you mentioned kind of personal support workers, and then you mentioned also the family members and the individual themselves. So, I mean, is there sort of any best practice on sort of the collaboration between all the different kind of health and support workers in order to deliver the best care possible?
Yes, it's, as the doctor had mentioned, it's not just about, okay, you're saying you're doing person-centered care, and it's used quite loosely. People are saying we do person-centered care. Well, actually, they're not. There's no modeling or framework that they've implemented. It's continuous sending information and education to the personal support workers. It's orientation. It's so we have somebody dedicated to person-centered care. They're going out and doing the home visits. They're connecting with the personal support workers. Once there's conversations with the personal support workers, We also have activity kits and all different types, and music and all sorts of things. So the caregivers, can call us. And when we have conversations in the home with either the client or the family or the personal support worker, we're gathering that information. It's ongoing. It's not just, as the doctor said, it's not just starting it off, okay, and you're doing, this activity or that. It's continuous and you're always learning. The other thing is we have a software program, and many of the software programs within the private home care industry, and also, in the hospitals or community agencies, are still a medical lens model. So what needs to happen in order to provide a person-centered care? You're having to adjust your software systems to be person-centered. So for instance, when our caregiver goes into the home, they have to explain to us what they actually did, not just on the medical part of the showering, changing, feeding, and they're just checking the boxes, as the doctor said. No, they have to provide us what was their meaningful conversation for the day. Did they go for a walk? Did they go to a cafe? We're also understanding about the social network around the individuals where they're living. What are the places that they may go and visit? Maybe they're doing some new things that they haven't experienced before. So there's new experiences that they're having with the personal support worker or the healthcare aide. We also have a system for families to sign on to, which is the family portal. And that way they can get pictures and updates and all sorts of things. And also calling our client services, who will spend time with them to let them know how their family member is doing. Many of the clients sometimes that we have, the family members are living, Australia, New York, and all these places. So we're having to provide that information. So yeah, it's quite a bit, and it's not just one time of saying you're doing that. It's like over and over and over again is embedding that into your culture. Thank you.
Yeah, thank you so much for sharing all that. And I think it's a lot of work, as you pointed out. So I mean, congratulations on the work that you're doing and sort of the progress that you've made as well. Yeah, Dr. Metzelthin, did you have any kind of comment or response as well?
Yeah, I see a lot of recognition what Jane told us. So I think that the systems, of course, have to support the way of working, and it would also help a lot if people working at different organizations could also communicate more easily with each other, and can also assess the registries of the other organization, because that is also a problem that we have, that, for example, the occupational therapist or physiotherapist in primary care cannot assess the home care registry. And what we also see, if people are moving from the home situation to a nursing home, for example, that also, there's so much knowledge about the person and the network, but this knowledge does not move to the next place, which is also, of course, a very big problem. And then, for example, you're allowed to take your chair and your furniture with you, but you have to leave your habits at the front door, which is a pity. Yeah. There's a lot of room for improvement.
Yeah, absolutely. So I think, is there, we've sort of mentioned, I think, that there's quite a lot of areas for, I guess, knowledge sharing, but also kind of sharing of best practices, but also maybe future areas of research in order to sort of optimize this care. And yeah, Dr. Metzelthin, is there, some research areas that you feel there's kind of a big gap, and where should we be moving towards in terms of filling some of these gaps in order to either further the implementation, further evaluation, and maybe make some strides in accessing this type of care?
Yeah, I think with regard to the implementation, of course, it will also be interesting to do more international research on which also context factors influence the implementation of reablement. So, like you all already introduced, the culture of different countries, but for example, also the policy. So, for example, do countries have a good dementia policy where also is a lot of emphasis on the well-being of people and being independent and stuff like this? So I think that could be quite interesting to also have a comparison of different countries and to also have a look where are they now with the implementation of reablement and what hinders them and what helps them to implement it. And how can we reach the next level, but also what can we learn from each other? Because I think in all different countries there are happening quite good best practices, and some call them reablement, and maybe some use other terms for it, or just call it person-centered care. And it would be very good, I think, to have more an exchange about these best practices, so that not every country has to find out it by themselves. So that would be really great.
Yeah, I agree. And Jane has mentioned that there's, in Ontario and Canada, there's, people meeting as well. And they're, looking at creating a master's program on future-centered care from the European Society of Person-Centered Healthcare in the UK. So I think both of those are great strides forward. And I think, I'm wondering as well, Silke, if there's any relationship to this and sort of integrated care. And so, we think quite a lot about sort of the integrated care of older people here at the IFA. But, is this being thought about within certain frameworks of integrated care as well?
Yeah, of course. I think reablement is a kind of integrated care intervention, because you try to integrate the different services and to work towards the client goals. But I think maybe we could also learn more about from the field of integrated care specifically, and how we can use this knowledge also for the further development of reablement services. Good point.
Yeah,
separated research fields are not so common.
Yes. Yeah. It seems to me that you almost want reablement as sort of your, a core piece of some of these integrated care frameworks when we think about sort of an idea of sort of how older people move through their sort of assessments when it comes to their sensory health, their physical health, their mental health, and all of these things. It seems like maybe reablement has sort of a spot within there somewhere. So yes, that would maybe be an interesting research lens as well. So I'm going to go to another question in the chat as well, which is a question about technology. So is there any sort of integration or connection with technology in reablement? So whether it's kind of smart home devices or different assistive technologies or AI, does that have any role in sort of the implementation, or is that sort of a way forward?
Yeah, I think technology is definitely also part of reablement, because that could be one of the intervention of your support plan to reach client goals. So for example, working with a medication dispenser, or also GPS tracking if safety is an issue. So these are definitely possibilities.
And has that been successfully implemented, or are there any kind of challenges or barriers?
So far, we do not standardize that if you work according to reablement, that you have to use a couple of technologies. So it's really tailor-made, and it also depends, of course, on the organization where Reablement is implemented, and we also advise to have a good look at the innovations that are already in place at the organization, and how can you also give these innovation a boost within Reablement. So for example, at the organization where I'm also a scientific advisor, they also invested a lot during the last years in smart technologies in the home situation. And of course, that can be technology that you can use to reach client goals.
And is there any sort of I guess maybe just to come back to some of the challenges, because I think while technology has, there's a lot of benefits, of course, but I think sometimes particularly with older people, and I can imagine with their caregivers and people with dementia care, there's also maybe sometimes a lot of hesitation with some new technology, especially if it's sort of unfamiliar. Do you hear any concerns, or is that something that comes up as well?
Yeah, it really depends on the specific situation. I think some people are more open already for new technology than others. And I think, in the upcoming decades, it will also become more usual to make use of technology, so that piece will be easier also in the future. So the acceptance of technologies will increase, I think.
So we are kind of coming to the end of the hour here. So I wanted to come back to sort of one last question, which is around sort of a rights-based framework to care. And I think we talked about this a little bit at the beginning, which is that, people, the principles of reablement really focus on that everybody would have access to them. So can you maybe talk about how reablement also supports maintaining the rights of people, their kind of right to care, their right to have good health and well-being, or best quality of life?
Yeah, I think it starts with the right of people living with dementia, that they have to participate in meaningful activities. And also we see in studies that they also want to have a meaningful day, but also that it wants to have a meaning to the society. And I think Reablement is a way in supporting them to do so. So should also be accessible to them, and not only to people who have the chances to recover, for example, from a stroke or whatever. So it should be more open also to them to increase their well-being unless the dementia.
And is there more research that's needed to understand how to implement and evaluate in these different specific instances, like dementia, stroke you mentioned?
Yeah, I think we should definitely also do more research into the beliefs different stakeholders have about reablement and dementia care. So I can also imagine that the attitude of staff is different towards the attitude of family caregivers, for example. So also to really have a look what is most important to the different groups, and what do we need maybe also to convince them that reablement is maybe also the better way to deliver care, instead of taking over tasks and reducing people in their freedom to choose what they like to do.
Yeah, absolutely. So I think we do just have a few minutes left of our session. So I'm going to take a moment here to introduce next week's speaker for our Global Cafe, and then I'll come back to you, Dr. Metzelthin, just for some key takeaway messages. All right, so next week we will have Professor Amanda Grenier, who will be joining us, and Professor Grenier is the professor of the Norman and Honey Skipper Chair in Gerontological Social Work at the University of Toronto. and she'll be speaking about centering the lived experiences and rights of older adults within public policy. So that should be a great session as well, and maybe also picking up on some of our conversation today as well. So just in the final kind of moments here of our global cafe, Dr. Metzelthin, if you want to kind of share your key takeaway messages from today's conversation.
Yeah, my key message would be that we should all spread the message that reablement and also delivering person-centered care is very important in dementia care, and that we should try our best to get to know the person and to understand them, and to support them in an adequate way to help to have a meaningful life.
Mm-hmm.
So that would be my key message. Yeah. Thank
Thank you so much, Dr. Metzelthin, for all of your insights today. Thank you so much for joining us, and also for everyone in the audience here of our Global Cafe. We greatly appreciate you showing up week after week and engaging with us on these topics. And as well, thank you to the IFA team that helps to support putting on the Global Cafe every single week, particularly Luana, who's with us every morning at the Global Cafe. And as we mentioned at the beginning, we have quite a few resources that Dr. Metzelthin shared on reablement, if this is something of interest, particularly on kind of the different definitions and on the status of implementation from kind of the Reable network. So we would encourage you to check out those resources, along with maybe learning a little bit more about our IFA Global Conference, which is coming up very, very quickly in September. So thank you all so much for joining us, and we greatly look forward to seeing you on the next Global Cafe.